Welcome everyone to another episode of Pulm Peeps and our second episode in our new series of our Pulm Peeps Fellows Case Files. I'm so excited to highlight another amazing case by a current fellow in training and to hear about another amazing fellowship program. How about you, Furf?
Hey, Christina. Yeah, definitely pumped. For a reminder for everybody, this series is really for two purposes. One is we just think there are amazing fellows around the country and the world who are hearing cases and they work really hard on these great case presentations. I think they're really memorable when you hear about them in the hospital, and we want to sort of amplify their work and spread it a little further. And the second is just to build a network of great training programs and educators that can come on Pulm Peeps and share some wisdom with us, which is why each episode the fellow will also be accompanied by the fellowship program director. And we'll be talking to two people today.
Absolutely, Furf. And on that note, if you're a pulmonary critical care fellow and have a great case you'd like to discuss, just send us a message on Twitter or email us, and we'd love to have you join the show.
Yeah, absolutely. And today we're thrilled to be joined by members of the Harvard Pulmonary and Critical Care Fellowship Program at Mass General Hospital and Beth Israel Deaconess Medical Center. Before we introduce them, just for a reminder, this podcast is not for direct medical advice. The case is HIPAA compliant and some details may have been changed to protect the privacy of our patient. And the viewpoints are our own and don't reflect the opinions or practices of our respective employers.
Great, and super excited to start with our introductions today. Our fellow presenter today is Dr. Brian Rosenberg. Brian is a third-year fellow at the Harvard MGH BI program. He completed his undergraduate degree at Harvard and received his MD from Yale, where he also got a PhD in cell biology. So I'm sure you were really busy during that time, Brian, and a lot to share with us. Brian then finished and went on to do his internal medicine residency at Columbia University Medical Center in New York. And we're so excited to have you join us today. Welcome to Pulm Peeps, Brian.
Thanks for inviting me.
Next, we have Asha Anandaya. Asha is an assistant professor of medicine at Beth Israel Deaconess Medical Center and Harvard Medical School and is the program director of the combined MGH-BI Pulmonary Critical Care Fellowship. She's also the director of the Pulmonary Consult Service at BIDMC, was a Rabkin Fellow in medical education, and has received multiple leadership and teaching awards. It's great to have you on the show today, Asha.
Thank you so much, Dave and Monty, for inviting me. I'm so glad to be here.
Yeah, well, I definitely can't wait to dive in. So, Brian, why don't you tell us a little bit about the case you have for us today?
All right, so this is a case of a 30-year-old gentleman who was at his baseline state of health until 2 months prior to admission when he presented to an emergency department with bilateral lower extremity edema and erythema. Basic lab workup during that ED visit revealed leukocytosis, creatinine of 1.47, and an NT-BNP of 6,600. Admission was recommended, but unfortunately he left against medical advice and was given a prescription for oral Bactrim and Keflex to go home with. He now presents to the hospital with worsened leg swelling, subjective fevers and chills, and progressive shortness of breath to the point that his mother says that he can now barely breathe. The shortness of breath is sometimes accompanied by a sense of lightheadedness. And over the past week, he has also been intermittently coughing white and sometimes pink-tinged sputum and reports that his urine is occasionally reddish in color. He also told us that he experienced some nausea and vomiting over the past few days.
Well, Brian, that definitely sounds like there's a lot going on with him. And before we dive in a little bit further, I was wondering if you could round out the rest of the history for context, anything else that you'd want listeners to know at this time.
Sure. He also had a history of substance use disorder, was actively using cocaine, IV opioids, cigarettes, and marijuana. He had a history of untreated hepatitis C infection and a remote history of craniotomy that was done for a traumatic brain injury that he didn't have any sequelae from. No allergies of note, and the only medication that he was taking was Adderall. He denied any significant family history.
Yeah, this is a interesting presentation. You know, anytime I meet a new patient, my personal diagnostic approach is just try to frame them with a problem representation, because I think that gives me a way to start diving into either diagnostic schemas or thinking about their pathophysiology. And this is a tough one for that because there's so much going on. So, I'd summarize him, I guess, in a problem representation as a young man with active polysubstance and IV drug use who's presenting with dyspnea, productive cough, lower extremity edema, fevers, and hematuria 2 months after a presentation with AKI and maybe some cardiac strain on labs. The reason I say this is tough is because that's a mouthful. And this isn't just one schema that I'm thinking of. It's not just lower extremity edema and dyspnea, which kind of goes me down one pathway. It's not just fevers and productive cough, which is another pathway, but it's trying to kind of look for the overlaps of that. So, at this point, the differential is so broad that I probably would just dive into examining him to start narrowing it down.
Totally agree, Firth, and definitely a very broad differential that we're probably all thinking of right now, as you mentioned. And I'm really honing in on the fever in your problem representation, leading me towards sort of an inflammatory versus an infectious process at this time. He does have tons of risk factors too, which Brian mentioned, including his IV drug use, which could predispose him to soft tissue infections, bacteremia, as well as endocarditis, or even, severe syndromes such as toxic shock syndrome. Another thing that's important to note is that his hepatitis C would be a risk factor for vasculitides. And on that note, I wonder about his prior creatinine elevation and if that was just an AKI or is that now a progressive trend now that we see hematuria as well. And I wonder if he could be having an evolving nephrotic syndrome or something similar such as that. Brian, I was wondering if you could let us know about any pertinent exam findings at this time.
Absolutely. So at the time of the exam, his temperature was 37.2, his heart rate 111, his blood pressure was 85/54 with a respiratory rate of 16 and saturation of 98% on room air. And the notable exam findings were that he was tachycardic. He was noted to have a 3 out of 6 systolic murmur, most prominent at the left lower sternal border. His lungs were clear to auscultation bilaterally, and he did have 2+ pitting edema with and a very notable skin exam. He had scattered lesions on both his bilateral upper extremities and lower extremities. And I'll try to describe them as best as I can, but hopefully we can get some pictures up as well. The lesions were red, some almost purpuric, some more petechial, and most of them were palpable when you ran your fingers over them.
Yeah, so I think definitely some significant findings, Brian, and I think things, that may kind of be fitting into some of our, infectious versus inflammatory differentials, and I wanted to go a little bit further and how were you tying in, his hemodynamics as well as the physical exam findings, Brian, and kind of what were you thinking of as, expanding on the differential or any other kind of further thoughts that you had at this time for him?
Certainly some things on exam and in his vital signs that are of concern in terms of his more immediate course. The first thing that I point out is that his heart rate is higher than his systolic blood pressure. So his shock index is greater than 1 and significantly greater than 1. So, we know that he probably is in shock at this time and certainly has a high risk of further decompensation. To get to the other exam findings, he had no documented history of a heart murmur beforehand. So, in someone this sick, thinking about things like a new endocardial lesion, like endocarditis, or a valvular lesion that's acute and causing his decompensation was in the forefront of our minds. Evidence of systemic congestion, the pitting edema that he had, again in conjunction with the clear lungs, certainly raises concern that there might be a right-sided cardiac process involved. Although at this point in time, you'd have to consider other causes of edema that aren't cardiac in origin as well.
You mentioned something that I'm just going to point out because I think it's a great point. The shock index, heart rate over systolic blood pressure. And for our listeners who don't know, this is an index that was first sort of manifested in the trauma literature, looking for sort of occult hemorrhage, and values greater than 0.9 had a high predictive mortality. And then since then has been sort of studied and validated in conjunction with infectious signs for sepsis mortality. And it's a really nice, just very simple bedside measure to look at. So I'm glad you pointed that out. I'm going to want to go to you next, Asha. I have a question about these skin findings. As Brian is alluding to, they're important. I think they're really important in any ICU patient, especially someone who's really sick. That being said, I'm really bad at the skin exam. I'm even worse at describing my skin exam. And so I'm just kind of wondering your approach to skin lesions or new skin findings in a critically ill patient in the ICU.
Yeah, Dave, I totally agree. I don't consider myself to be a very good dermatologist. So I would say I take a pretty simplistic approach, acknowledging that in my approach to patients that come in critically ill with skin findings, and try and just put them in one of maybe three buckets. So thinking about sort of one bucket being, probably unrelated to critical illness. So if it's something that looks chronic, something that's easily identifiable even to those non-dermatologists, of a chronic condition, or something that just doesn't line up in terms of timeline, isn't associated temporally with the critical illness. If you know that from the history, that's one bucket. I think the other bucket that you definitely want to sort of the don't miss bucket in the acute setting is sort of considering the possibility if there's a prominent skin finding that it could be sort of driving the critical illness in the primary process. That's relatively uncommon, all things considered, but certainly infection, most commonly a skin and soft tissue infection, for example, and making sure to do a thorough exam, highlight or draw lines around any areas of concern and that sort of thing. The other sort of bucket in this category would be the sort of Stevens-Johnson's toxic epidermal necrolysis spectrum, of adverse drug reactions typically, although sometimes from infection, that can actually sort of be the primary diagnosis presenting with the skin findings. Typically, we think about, examining the mucous membranes if there's a significant rash as a way to sort of preliminarily assess for that possibility. So there are a couple of things in that category. And then the last bucket, which I think this patient probably falls into more so is, are there skin findings that are a clue to an underlying systemic disorder? And that's where, I think, certainly, certain infections, meningococcemia, or certain staph infections, and as well as other inflammatory disorders, potentially vasculitis with palpable purpura, you mentioned in this case, or some of the ones that come to mind. But that's where I would say I would have a low threshold to actually consult derm and get them involved and not rely necessarily on my ability to identify those in any specific fashion, but rather to kind of reach out to the experts early, understanding that there may be some important clues there, and also that, more often than not, derm's going to want a biopsy, and that's going to take some time before it comes back. And so getting them involved early, if you think the rash is a good clue, I think is a reasonable approach.
There's nothing we like more than a simple and bucketed approach. So that's perfect. I love that. Brian, can you let us know about sort of the additional workup the patient had at this time?
Sure. The first pass workup was notable for a significantly elevated BUN into the hundreds, a creatinine that was also significantly elevated from his baseline, hyperkalemia, low serum bicarbonate. His CBC was notable for a leukocytosis that was PMN predominant, as well as an anemia that was normocytic with a slightly elevated platelet count. He had mild transaminase elevation and mildly elevated INR. His CRP and ESR were both elevated, and his troponin was elevated and had a rising trajectory. As was noted before, he had an elevated pro-BNP. And then also of interest, his urinalysis had 1+ protein, 3+ blood, no nitrates or leukesterase. And on the micro, had 3 to 5 white blood cells and many red blood cells. The EKG is also quite notable, and I'll try to describe it here. It was sinus rhythm, but he did have a borderline right axis deviation, a dominant R wave in V1, T wave inversions, and subtle ST depressions in the anterior leads, and an incomplete right bundle branch block pattern. A chest x-ray was also obtained that was notable for an enlarged cardiac silhouette and mediastinum, and also some middle to upper lobe infiltrates, particularly on the right, and some air bronchograms and some infiltrates on the left. There was no evidence of pleural effusions or pneumothorax on that.
Thanks so much, Brian. That certainly does add a lot of information, to the case. And while not yet consistent with one unifying kind of diagnosis or picture for me right now, we are definitely getting a lot of hints that are kind of pointing us in certain directions. And I think the three big categories of findings that you pointed out for us on the labs include the following. And I think the first is renal failure, as you mentioned, which for him is acute to subacute based on his prior creatinine measure. And thank you for bringing in, the UA findings in here as well, because this does suggest to me possible glomerular involvement. The next kind of set of our category that I'm thinking of is inflammatory infectious response, with you mentioning the leukocytosis, the normocytic anemia, thrombocytosis, and then elevated inflammatory markers. And then the third are signs of myocardial strain and ischemia. You mentioned, there's elevated pro-BNP, and I know sometimes that's a little difficult to interpret with acute renal failure, but I think you mentioning the troponemia as well as the abnormal EKG findings with evidence of right heart strain, and also tying in his chest x-ray, which is showing an enlarged cardiac silhouette. I'm definitely starting to think about cardiac ischemia, myocarditis, or even a PE. So in total, I'd be looking for something to unite all three of these, and my leads are still an endocarditis or infectious picture, given the history and the significant skin lesions that you described, or an autoimmune disease or vasculitis, again, with all of this, including the skin lesions.
Yeah, I totally agree, Monte. We'll post this ECG online, but I think it's, you described it very well, Brian. It's really classic for an RV strain. Now, you'd want to see if he had prior EKGs that looked like that, but if he didn't, and this was brand new, and you had, troponins and proBNP, and a slightly different story, like not acute renal failure, but someone came in like that and had sudden syncope, sudden chest pain syncope, that may be enough to just like start activating thrombolytic pathways as you're continuing to work stuff up. So I think it's a really important point to emphasize the right-sided strain. I definitely want some more tests to look into that. So, thinking about a CT and an echo. And then I think this always raises an interesting question. And Asha, I'd be curious your opinion. A lot of times in this situation, you'd love to get a contrasted scan. You'd love to see the pulmonary arteries. Is there PE? Also, just kind of if you're thinking about inflammatory diseases, may be helpful. But we know he has a new acute kidney injury. So I don't know that there's a right or wrong answer, but I'm curious how you approach these scenarios.
Yeah, Dave, I agree. It's always comes up so often in the ICU, and it's often kind of a tough call and something sometimes can hem and haw about. I think overall, the literature around contrast-induced acute kidney injury has, I think, evolved into sort of in the bigger picture outside of the ICU in this type of case, suggesting that maybe what we used to think was contrast-induced AKI more likely is often associated and rather than sort of necessarily causative. So that kind of strong association we have kind of in all patients maybe is less strong than we think. But I still think an area of controversy, and certainly nobody has really studied this population, the evolving AKI population, where certainly they have many reasons that they could continue to have an AKI, but where we worry about any possible additional insult, such as contrast. And I think, there's definitely no one size fits all here, like with most things in the ICU, and a really case-specific approach and thinking about the relative risks and benefits. Sometimes there are cases where, you can take an alternative path to identifying, thromboembolic disease, for example, with diagnosing a DVT, if you could do an ultrasound, it could be enough information for you in terms of therapies. Or, some cases empiric anticoagulation may be reasonable or all you have if you really can't move a patient. I think in a case like this, where the stakes are pretty high with everything you guys have discussed around the potential for for PE specifically, with respect to, some of the potential even other therapies that might be invoked. I think that you kind of have to bite the bullet in a case like this, and in many cases in the ICU, and go ahead and proceed with contrast, knowing that there may be some trade-off there, although of course never knowing for sure.
Sure. So he went on to get a CT scan with contrast, which was quite revealing in this case. And I'll highlight the most prominent findings here. First, and to my mind, the most unusual was that there was concentric soft tissue surrounding the main pulmonary artery and extending into both the right and the left pulmonary arteries, and also surrounding the aortic root and aortic arch and the origin of the great vessels. There was indeed an acute pulmonary embolism. So this was done with contrast, but it was non-obstructive and only involved the medial segment of the middle lobe pulmonary artery. Really, there wasn't any other clot burden. There was also a moderate pericardial effusion. There were CT findings suggestive of right heart strain as well. There were ground glass opacities in the right upper lobe in particular. And there was sub-centimeter mediastinal lymphadenopathy on both sides, and very small pleural effusions bilaterally as well. I can also talk about the echo findings. So his left ventricular ejection fraction was 79%, and really the entire left side of his heart was normal. The right side, however, was grossly abnormal. He had a dilated right ventricular cavity. The entire right ventricle was diffusely hypokinetic. And then most interestingly, he had a finding of flow acceleration across the main pulmonary artery distal to the pulmonary valve with a mean gradient of 42 millimeters of mercury. His RV systolic pressure, as estimated by the jet of tricuspid regurgitation, was 106 millimeters of mercury. And they also were able to note, even though it was a transthoracic echocardiogram, that there was narrowing of the main pulmonary artery and what looked like thickened main pulmonary artery walls.
Wow, Brian, that's so much to take in, and thank you for describing it. I'm trying to kind of start to think in my head, create images in my head of what this looks like, because there's so many, abnormalities, and we'll definitely post some CT and echo findings online for everyone to kind of follow along, and since they're pretty impressive. It certainly seems like there's significant RV strain, as you mentioned, as well as the PE. But what's really striking to me is the soft tissue thickening and stranding around the PAs and aorta, and something, I haven't seen that often, and definitely not something that we are used to seeing with a diagnosis of PE. So, Brian, I'm interested to know, what did you and the team start to think about with all of this new information?
Yeah, there are a lot of interesting features to this case. Certainly, multiple organ systems are involved. To focus on the most striking imaging findings, which I think is the large vessel involvement, both the pulmonary artery and arteries and the aorta. So definitely an unusual finding on CT, and definitely brings to mind an inflammatory process in those vessels. So they're both infectious causes of those findings, but I think what we were more thinking along the lines of is a non-infectious inflammatory cause of those findings. And so the main things on the differential for large vessel vasculitis that affect both the pulmonary artery and the arteries in the aorta are Takayasu's arteritis, particularly in someone who's a little bit on the younger side, like our patient was. In the older population, giant cell arteritis can definitely do this. And then IgG4 disease is definitely in the differential as well. And less commonly, other connective tissue disorders can also cause these findings. The other thoughts that the team brought up is whether and we actually went down to radiology to discuss this, there were no evidence of pulmonary artery aneurysms. It was just soft tissue thickening of the walls. But if there were aneurysmal elements to the pulmonary artery vessels, you might add diseases like Behçet syndrome and Hughes-Stovin syndrome to the differential as well. Much less commonly, diseases that can usually cause small vessel pulmonary vasculitis can have large vessel involvement. So conditions such as the ANCA vasculitides, as well as other medium and small vessel vasculitides are still in the differential, but perhaps a little bit less likely at this point. But, to zoom out again, this patient had evidence of both skin involvement that did really suggest small vessel disease and possible renal disease. And so even though based on the pulmonary imaging findings, the small vessel vasculitides seemed less likely to explain that, I think we all thought we needed to keep a fairly broad differential at this point in time, given the variety of the findings that we encountered in this patient.
Yeah, I think that's a great summary of trying to put together a really odd finding with sort of in context of the rest of the systemic. You mentioned some, like, you could consider infections, like I guess syphilis can do a large vessel vasculitis, and I think the endemic fungi can do anything if they want to in a compromised patient. But putting it together, it really doesn't sound like that would be a description. So I think that's a great way to sort of approach it. One thing I did want to just point out, because I it's a pearl that I was taught long ago that I think is really important. This patient, you did a nice job telling us how the PE is probably not the main driver. He has a flow acceleration in the PA, is unrelated to the PA, it's not obstructive. But the other thing too is there's just no way all of this RV dysfunction is brand new with an RVSP of 106, right? So, RVSP can get really high in acute PE, but anything above that sort of 50 to 60 range, the RV would just blow out if it was a brand new obstruction. And so you kind of know there's something else that's been going on. With these findings and hypertension on presentation, I imagine this patient was pretty sick, and stabilization is sort of a key part of what's going next. Asha, given all the tests that the differential that Brian talked about, what kind of tests would you want next for this patient so that while they're being stabilized, we can figure out what's driving all of this?
Yeah, I think Brian was starting to get into that. It's such an interesting finding with these large vessel type of involvement. I think, like you were both saying, sort of unexpected. And I think, in thinking about some of the vasculitides, like Brian was mentioning, some of the ones that typically involve large vessels don't necessarily have serologic tests, as compared to ones we think of smaller vessel, the Takayasu's or giant cell. But I think, certainly casting a broad net and testing serologically for the things we can would make a lot of sense. And I think the sort of general vasculitis panel, including sort of the ANA and with that complement levels and the antiphospholipid panel, I think he had a history of some IV drug use and maybe hepatitis. So thinking about cryoglobulins, the sort of ANCA, GBN, sort of thinking about the pulmonary renal, which he also has sort of concern for based on the presentation, a UA, if we didn't already have one. And then you mentioned IgG4 as a consideration, Brian, so you can send a serum IgG4 level as well. So those are some of the things I think, hopefully I caught most of them on the kind of vasculitis inflammatory panel. And then Dave, you mentioned some of the infections that are probably still in the back of your mind. So broadly, right, you have blood cultures cooking. Hopefully you have fungal cultures, like you mentioned, the hepatitis panel and things like that go along with some of potentially a reason to invoke some of the inflammatory causes. And then a couple of those kind of rare, what can involve the aorta. You mentioned syphilis, TB I put on there. So maybe just sort of rounding out, with those considerations. But I think, ultimately you're always also at the same time thinking about tissue and where can you go to get a definitive diagnosis. Again, particularly with the sort of unusual aspects of this case. I know we often think about the kidneys as a relatively easy place to go if the kidneys are involved. And it does seem like with the presentation that in this setting, the kidney dysfunction is probably part of the underlying process and might be a good target.
Thanks so much, Asha. Yeah, I was going to ask that question, whether or not you would want to pursue a renal biopsy. So that makes sense. And, sometimes patients I deal with have a lot of thrombocytopenia, but this is not the case. So I think would be safe to proceed with that. Thank you for going over that for us. And interested, Brian, though, the patient sounds pretty sick right now. I think one that we would all be worried about. Can you tell us what's happened next with the patient's course?
Yeah, so he unfortunately got much sicker very quickly because of the renal failure and severe hyperkalemia. He required an emergent dialysis line placement, and became quite agitated during that, and because of that required intubation. After intubation, he became very hypotensive, requiring fairly high dose vasopressors. He was, of course, started on very broad spectrum antibiotics. In the context of his instability and the pericardial effusion that he had, even though there were no clear signs of echocardiographic tamponade, he did undergo an emergent pericardiocentesis and had 2 liters removed at the time. He also had a skin biopsy performed fairly rapidly, and a renal biopsy as well. All of the serologic tests that Asha mentioned were sent off and pending because of the concern for decompensated right ventricular failure. Received INO through his endotracheal tube and epinephrine for RV hemodynamic support, because of the very high concern that this was a fulminant inflammatory process on a gram per day of methylprednisolone empirically.
Yeah, I love that you outlined sort of everything that we're doing for him. And it's sort of a real punctuated point in this case that you're doing a lot without knowing exactly what's driving it. And you're sort of treating and doing management at the same time. So he's getting treatments broadly, antibiotics, he's getting steroids that you sort of pulled the trigger on. And then you're using your pathophysiologic understanding to stabilize him. He's intubated, fluid removal with CVVH. You're thinking about RV strain, so he's getting inhaled nitric oxide and epinephrine for RV support, and just such a common scenario in critical care where you're doing all these things at once. I think an important point just to point out is that he had this pericardiocentesis you mentioned with a lot of RV strain and reduced function. That's certainly a very high risk procedure, right? So pericardial effusion is a scary sign in somebody who has pulmonary hypertension, RV failure. And if you sort of lose that pericardial constraint that is helping the RV do whatever filling it can, they can sort of collapse right away. So luckily he did not sort of have that. Asha, I want to ask you, I'm asking you a lot of questions about where there's probably no right answer, but we always have to do it a lot. This patient, we don't know exactly what's going on. We have an idea, and they're started on a gram per day of methylprednisolone. So this is another common ICU situation and a pulmonary situation about starting high-dose steroids in someone, but we don't know the exact driver. So what thoughts do you have about that, and how do you approach that empiric process?
Yeah, Dave, I agree. There are lots of questions with no straightforward answer. So the answer is, thinking through the sort of specific aspects of the case. And I think this is definitely one of those situations, sort of kind of real time, tough decision making. And I think the biggest thing is, we know why we consider this. It's when we have a patient who seems to have an uncontrolled, progressive, what we think is most likely inflammatory process. And we're worried about the trajectory and either don't have another opportunity to get diagnostics, or they're going to take some time. And we don't think we have that time. I think thinking about what's in the sort of, that's in the sort of plus column for empiric pulse steroids. I think in the negative column is always, the first 3 things are infection, which is typically on our differential at some point in these cases, as we discussed in this case. And I think really doing due diligence and making sure we've done everything we can to exclude the possibility of giving pulse steroids to someone where there is an active infection that is still really seriously being considered. And I think in this case, at this point, we have probably a couple of days or some time in terms of culture data, which we typically like to see to help us with that. Certainly any type of infection, albeit I think the potentially most disastrous scenarios are in the setting of fungal or mycobacterial infection being kind of under consideration. So thinking about those in particular. And then, I think the other things to consider are, sort of, are there other diagnostics or not? Sometimes in those pulmonary situations you mentioned, there just aren't going to be any others. And so it's sort of the end of the road to make this decision. But if there's time. And then lastly, would giving steroids first cloud your diagnostics? That's sometimes a scenario that you have to consider in terms of the timing of things. But all that being said, I think certainly in a case like this, where the patient has, severe multi-system kind of organ failure, is progressing, and inflammatory etiology, in particular, something like a vasculitis, is sort of at the top of the differential certainly seems like a reasonable thing to do. And hopefully knowing that you have some pending diagnostics that'll help you in short order.
Yeah, totally agreed. Seems very reasonable in this case. And those are all the things that we always kind of think about. So Brian, smooth sailing from here after he got his steroids? How did the rest of the case go?
Oh, well, not exactly, unfortunately. The patient actually did start to improve for a day or so on a day or two on the high dose steroids, and all of the infectious studies that were sent, including bacterial, fungal cultures from essentially every site that we could culture, including an initial bronchoscopy after he was intubated, were no growth. But overnight, developed massive hemoptysis from his endotracheal tube and required an emergent bronchoscopy. The hemoptysis was diffuse, but the worst of it was coming from that right upper lobe bronchus, which, if you remember back to the CT scan, that was where the worst of his ground glass abnormalities were. And interestingly, a serial bronchoalveolar lavage revealed progressively bloodier specimens that was certainly suggestive of diffuse alveolar hemorrhage. But the bleeding was bad enough that the entire right upper lobe needed to be packed with a Surgicel type material by our interventional pulmonary colleagues to obtain control of the bleeding.
Glad that he was in the right place and with the right experts needed to take care of him. And, luckily we know from our prior hemoptysis episode with Chris Kapp and Matt Schimmel, from our recent case with Tess Lichman reviewing pulmonary renal syndromes, and you reminded us how to diagnose DAH, which was, specimens becoming bloodier on serial aliquots. But we also talked about some techniques in management, so make sure you take a listen to those again if needed. But I want to come back to the patient and summarize so far. So we have a young man with prior IV drug use as well as hepatitis C who presented with lower extremity edema, dyspnea, and skin lesions, who is now being admitted with acute renal failure, large vessel inflammation, and pulmonary emboli, complicated by severe RV dysfunction and shock, and in respiratory failure with large volume hemoptysis concerning for DAH. So Brian, we keep asking you, what are the next steps in the case, and we keep being surprised, but wanted to know kind of what happened next and if you and the team ultimately found out a unifying diagnosis for this patient.
Yeah, I think the two tests that came back in conjunction that were most useful were the results of the renal biopsy and a few of his serologic tests. So I'll just note that he did undergo the skin biopsy, which was not all that helpful in his case. It showed neutrophilic inflammation of the epidermis and dermis associated with necrosis and intravascular fibrin thrombi. But from talking to the dermatologists and the dermatopathologists, the differential diagnosis of that particular finding is rather broad. The renal biopsy was a bit more specific. So it had a number of findings. The first was active and chronic crescentic glomerulonephritis with 80 to 85% of the glomeruli showing global glomerular sclerosis. But interestingly, in conjunction with that, he had evidence of linear IgG staining on immunofluorescence along the glomerular basement membrane. Given those findings in the hemoptysis, we were all very interested in what the anti-GBM antibody result would be. And interestingly, in him, it was negative. In fact, really the only positive serologic finding out of all of the vasculitis serologic workup that Asha mentioned that returned positive was his ANCA results. So he was p-ANCA positive with a ELISA titer to myeloperoxidase that was in the 30s, so quite elevated, and his ELISA for proteinase 3 antibodies was negative. Based on those findings, and of course, we had involved our nephrology colleagues and rheumatology colleagues at a fairly early time point, and as well as our cardiology colleagues, and this was really a great case for for interdisciplinary management and discussion, and given the complexity of all of the features of this case. And the final diagnosis that we settled on was that this patient had an overlap of GBM antibody negative anti-GBM disease with MPO positive ANCA-associated vasculitis with large vessel involvement, which had resulted in him in severe pulmonary stenosis and right heart failure, acute on chronic crescentic glomerulonephritis, and diffuse alveolar hemorrhage.
Wow, pretty amazing. I mean, we had a anti-GBM case before, but to have this overlap syndrome and anti-GBM negative, where you know it's happening pathophysiologically based on the staining, but you don't have the antibodies. It's a pretty crazy case altogether. You mentioned some of this before, Brian, but we think so much about small vessel vasculitides in pulmonary because that's the vessels we're often dealing with. But large vessel is pretty rare and something we see less. I think you started to review it earlier, and I think a great point for our listeners. Can you just tell us again, what you think about with large vessel involvement in a vasculitis for pulmonary patients?
Yeah, it's quite unusual, and our patient had a number of relatively rare findings. Normally, in isolated large vessel pulmonary vasculitis, you think of diseases that can affect the large vessels, including the pulmonary artery and aorta, of course, as well. Like Takayasu's arteritis in a younger patient, giant cell arteritis in an older patient. IgG4 disease is certainly on the differential as well. And like I mentioned earlier, if there were evidence of pulmonary artery aneurysms, you could think of Behçet's disease or Hughes-Steuven syndrome as well. But he actually had a rare presentation of a rare condition. So pulmonary artery and large vessel pulmonary artery involvement in ANCA vasculitis is rare, but has been described, and it can both cause an aortitis and a pulmonary arteritis, and cause both thickening of the vessel wall and stenosis of both the aorta and its large branches, and as well as the pulmonary artery.
Thanks so much, Brian, for sharing that. That's kind of an approach to start thinking about things for large vessel vasculitis, as you talked about. So I'm interested to know what happened as far as further management with this patient. How did he ultimately do?
He was treated with a few different modalities, again, in conjunction with our rheumatology and nephrology colleagues. He got the pulse dose of steroids. He also received plasma exchange because of the concern for GBM disease, cyclophosphamide, and rituximab after his plasmapheresis. He was started on sildenafil for concern for pulmonary hypertension when his shock had resolved. And, there was, given the significant pulmonary artery stenosis in conjunction with our cardiology colleagues, some consideration of whether he would benefit from stenting of his pulmonary artery, either in the acute phase or in the chronic phase. And this has been described in the literature. It's fairly uncommon to do, but the case series that have been described are mostly in either patients with Takayasu's arteritis or, to a lesser extent, giant cell arteritis. But the real preference among the interventional cardiologists who do this procedure are to do it when the inflammation has resolved, because in talking with them during the acute inflammatory episodes, the tissue tends to be very friable, and there's a risk in doing this procedure of pulmonary artery rupture. And so they prefer to do it once the disease, inflammation at least, has been better controlled. So with that treatment, his MPO antibody titer declined. He clinically improved. He did require a tracheostomy because his improvement wasn't quite that rapid, but he was eventually decannulated months later and is doing better overall.
I think this was just another great episode and a case that we were so glad to highlight in our Fellows Case File series. I think one of the reasons Furf and I wanted to do this was just to get diversity of cases that we may not see at our own institutions, as well as, to be exposed to great educators such as you and Asha. So we really appreciate you both coming on for the show. One of the things that Furf and I like to do with each case is have one takeaway point. And Furf, I'll start with you. What's one point from today you want listeners to remember?
Yeah, I think I'm gonna go with Asha's buckets for skin findings, because I think it's a helpful, pragmatic way. Is that you're sort of deciding quickly: do you think this is true, unrelated? Is this actually driving the process? And that's a really acute scenario where you want to do something right away, or is this just a clue to the underlying process? In which case, you could go for biopsy or dermatology consultation to figure out the diagnosis. What about you, Monty?
I think for mine, I feel like I'm going to put Asha on speed dial. Next time I need help talking about whether or not I want to give contrast to someone with kidney failure, or if I'm going to start pulse-dose steroids, I'm going to call you, Asha, and just have you walk it through with me. And I think this was just a great case, though, overall, just of how important the physical exam findings were and diagnostics earlier on the case. We had several significant pertinent exam findings that Brian talked about, and including his EKG as well as chest x-ray. I think that was just great to kind of start leading into our differential and kind of start thinking of big buckets before we went further into diagnostics.
Brian, any takeaways for you after this case?
There's so many. It's hard to choose just one. I think, maybe I'll cheat and just give two. So, the first would be, I learned a lot about small and large vessel vasculitis. And in particular, I thought it was quite interesting that a significant percentage of the time patients with glomerular basement membrane disease will not have a negative antibody titer in their serum. And so particularly the patients who, we think of who have diffuse alveolar hemorrhage and may not have prominent renal involvement, and we don't have the benefit of a biopsy. It's not something that you can necessarily rule out with a negative serum GBM antibody. And I think the other takeaway from this case that I would put out there is that the importance of interdisciplinary collaboration and discussion in these really complicated multi-system diseases, and getting your consultants involved early and often, and benefiting from their wisdom. And that's something I really like about our specialty, whether it be on the consult service or in the medical ICU, is that you get to take care of patients with these multi-system diseases, and both learn a lot and get to collaborate with some of our great colleagues in other specialties as well.
Asha, something you'll take away?
Yeah, you guys took a bunch of great ones. I love that last one though, Brian. I think the interdisciplinary collaboration is what is a huge part of what makes our field fun, but I think the sort of real-time involvement and the importance of kind of communication is super important. I guess I'll just harken back to one small pearl that you mentioned, Dave, which was the EKG in this case. When you sort of mentioned that, just that EKG alone, how much information you took from that, because I think sometimes we do tend to skip ahead, right? We skip over the X-ray to the CT, we skip over the EKG to do the echo. And so I thought that was just a really nice pearl about how much in this case you could have gleaned from the EKG. And so just like a reminder to myself, sometimes who can skip over that a little bit to pay attention to that. So
yeah. I did have one case once where the patient had a severe contrast allergy and was doing very poorly and had EKG like that in a classic story and got TPA based on that alone, which is not typical. So finally, we love doing these case files just to hear these great cases, but we also want to build a network of these great training programs and people to call on, and experts and educators from across the country. So just hoping you guys can tell us a little bit more. Brian, maybe some special things or one special thing about the Harvard MGH BI fellowship that you're in right now.
Yeah, no, again, hard to narrow it down to one thing, but I think one thing just to echo my previous point, one of the things that this case brings out in particular is just the very collaborative nature of our fellowship program. And I think, from my perspective, really the people make the program, and both the faculty and in the pulmonary and critical care division, as well as in other divisions, are always willing to help out and collaborate in these really complicated cases. And when it comes to finding a research project later on in your fellowship as well. So it's something that's really made my fellowship a really great experience.
That's awesome to hear, Brian, and so great, and just love that collaborative environment that you have there. And Asha, as we kind of are going into a new academic year, I'm sure, and just know that how busy you are kind of with the fellowship program, and so glad that you can join us today. But wanted to definitely get from you and hear from you anything that you want to share with our listeners about the fellowship program and why and how much you love it.
Yeah, thank you so much. Thanks so much for having me. And I love what Brian said, because I do think the people make the program, both like the people kind of close to home who sort of teach and mentor the fellows and their co-fellows, but also the culture of the institutions. And I think we're really fortunate. We're also heading right from new fellows and into recruitment season. So this is great timing for me. I'm sure you have a lot of, junior learners, fellowship applicant listeners. And I would say, our program is, in addition, to a great place with a lot of great people, you get to see amazing clinical cases like this one that Brian shared. And we're also a program, I think, that on the other side of things really intensively supports people in an individualized way to kind of discover what their academic passions are in this very large field of ours, and then really kind of, intensively supports them to pursue mentorship and skills and all the things they need to kind of lay the foundation for an academic career. So it's been, Brian's a great example of that among many others. And Dave's a great example of our really amazing, faculty who mentored them along the way. So thanks so much.
Yeah, thank you both for coming on. Thanks for sharing the case. And thank you all for listening. We'll see you in a couple weeks for our next episode. This case was produced, edited by myself and Christina Montemayor, and the music is original music by Eric Rogers. We'll see you next time.